This video is going to cover the entire respiratory chapter starting on page 544 from First Aid for the USMLE Step 1 2013 edition. A few helpful tips while watching these videos is that if you would like to pause the video, hit the spacebar on your keyboard. To fast forward the video by 3 seconds, hit the right arrow key on your keyboard. And to go back 3 seconds in the video, hit the left arrow key. Respiratory anatomy, the respiratory tree. What makes up the conducting zone of the respiratory tree? The conducting zone is made up of the nose, the pharynx, trachea, bronchus, bronchioles, and the terminal bronchioles. So it goes all the way from the nose to the terminal bronchioles. What is the function of the conducting zone? The function of conducting zone is to warm, humidify, and filter air that we breathe, but it does not participate in gas exchange. This is the area that is considered the anatomical dead space because there is no gas exchange that occurs here. What type of cells and tissues are seen in the conducting zone? In the conducting zone, there is cartilage and goblet cells that extend all the way down to the bronchi, and there is also pseudostratified ciliated columnar cells that extends all the way down to the terminal bronchioles, which is responsible for taking the mucus up and out of the lungs. What is the respiratory zone? Respiratory zone is the lung parenchyma. It consists of the respiratory bronchioles, alveolar ducts, and alveoli. This is the area of the lungs that participate in gas exchange. What type of cells are seen in the respiratory zone? In the respiratory zone, you have mostly cuboidal cells in the respiratory bronchioles, and then you see simple squamous cells up to the alveoli. This zone does not have any cilia, and the alveolar macrophages are what clears the debris and participate in immune response at this level. Pneumocytes. What are type 1 pneumocytes? As we mentioned a few minutes ago, that there are squamous cells that go up to the alveoli, and these squamous cells make up 97% of the alveolar surface, and they also line the alveoli. So these are the type 1 pneumocytes, and since they are squamous cells, they are thin for optimal gas diffusion. What are the type 2 pneumocytes? Type 2 pneumocytes are the cells that we mentioned a few minutes ago. They are the cuboidal cells in the respiratory bronchioles. These are the cells that are responsible for secreting pulmonary surfactant, and surfactant is important because it decreases the alveolar surface tension and therefore preventing alveolar collapse. So basically, surfactant will just lubricate the alveoli and therefore preventing its collapse. And collapsed lung is what's referred to as atelectasis. One additional thing to note about type 2 pneumocytes is that they are precursors to type 1 cells. So basically these can differentiate into type 1 cells, or they can differentiate into other type 2 cells, and these are the cells that you would also see proliferating when there is lung damage. What is the collapsing pressure of an alveoli? The collapsing pressure is 2 times the surface tension divided by radius. And the reason this is the equation is because an alveoli has an increased tendency to collapse on expiration, because during expiration the alveoli radius is decreased, and this concept is referred to as the law of Laplace. Describe the content of surfactant. Pulmonary surfactant is a complex mix of lecithins, and the most important of this is dipalmitol phosphatidylcholine. One additional thing to note about surfactant is that the synthesis of surfactant begins around week 26 of gestation, but the mature levels of surfactant does not happen until week 35 of pregnancy. And the reason this is important to know is because in premature babies, they might not have mature levels of surfactant, and this can lead to breathing problems. What are Clara cells? Clara cells are the non-ciliated columnar cells that have secretory granules, and these are the cells that are found in the bronchioles to protect the bronchial epithelium. Describe how Clara cells protects bronchial epithelium against toxins. Clara cells protects the bronchial epithelium by secreting components of surfactant, and this degrades toxins via cytochrome P450. One additional fact about Clara cells is that they act as reserve cells. What does lecithin to sphingomyelin ratio greater than 2 indicate? Lecithin to sphingomyelin ratio greater than 2 in the amniotic fluid indicates fetal lung maturity. Alright, now before we move further, we're going to briefly talk about how gas exchange works. This picture that you're seeing on your screen is not included in the book, but it's worth mentioning it just so you're familiar with sort of the anatomy as well as how gas exchange works. Now first of all here, you see that arteriole is bringing in deoxygenated blood to the alveolus for it to get oxygenated. So first the blood comes in, it gets taken up, and this is the deoxygenated blood that comes out of the arterioles and gets taken up by the alveolus. Here, the gas exchange is going to occur, and then the blood will get put into the capillary, where it will go through the venules and makes its way to the heart for it to get pumped throughout the body. So that's basically how gas exchange works. Now, also to mention, let's talk a bit about the anatomy that we have already discussed. Now you see that the alveolus is covered by that thin type 1 squamous epithelium, which makes up 97% of the alveolar surface. So you see that here. You also see the type 2 cells, which contains lamellar bodies, and those lamellar bodies are what secrete surfactant. Anatomy of the lung and lung relations. How many lobes does the right lung have? The right lung has 3 lobes. How many lobes does the left lung have? The left lung has 2 lobes, but it also has a lingula, and this lingula is the homologue of the right middle lobe. The reason the left lung does not have a right middle lobe is because this space is occupied by the heart. One funny note to help you remember the lingula is that the word lingula is derived from Latin and is derived from the word that means little tongue. So lingula can be thought of as being the tongue of the lung. What part of the lung does foreign bodies commonly lodge in, and why? Foreign bodies commonly lodge in the right lung, the reason being the right main stem of the bronchus is wider and more vertical. That means just because of gravity, the foreign body will go straight down into the wider and straighter right bronchus. Describe what would happen if you aspirate a peanut while upright. If you aspirate a peanut while upright, because of the right bronchus is wider and straighter, the peanut will go to the lower portion of the right inferior lobe. What would happen if you aspirate a peanut while supine? If you aspirate a peanut while supine, the peanut would still go into the right inferior lobe because of the wider and straighter right bronchus, but because you're supine, the peanut will go into the superior portion of the right inferior lobe. Briefly, describe the anatomy of the lung. We have already mentioned most of the things that we're going to talk about here, but we will briefly just go through the anatomy and how the lung looks from an anterior view and a posterior view. So if you look at the anterior view, the right lung again has the 3 lobes. It has the superior lobe, middle lobe, and the inferior lobe. Now the superior and the middle lobe is divided by that horizontal fissure, whereas the middle lobe and inferior lobe is divided by the oblique fissure. Next, you can also see the left lung, which has the superior and inferior lobe, as well as the lingula. Couple of things you may also want to notice here is how the lung is situated. Now, if you look at the left anterior view, you see that the superior lobe is situated more anteriorly. The reason you could tell this is because on the posterior view of it, you could barely see the superior lobe because you could only see the top part of it, but on the anterior view, you could see most of it. So that means that the superior lobe is situated more anteriorly and the inferior lobe is situated more posteriorly. And by using that same concept, if you look at the right lung on posterior view, you do not see the middle lobe at all. So this should basically indicate to you that when looking at the anterior view of the lung, the superior right lung is the most anterior, followed by the middle lobe, which is just behind it, and the most posterior is the inferior lobe. Diaphragm structures. What structure perforates the diaphragm at the level of T8? At the level of T8, the diaphragm is perforated by the inferior vena cava. What structures perforate the diaphragm at the level of T10? At the level of T10, the vagus nerve and esophagus are what perforates the diaphragm. What perforates the diaphragm at the level of T12? At the level of T12, the diaphragm is perforated by the aorta, thoracic duct, and the azygos vein. What is the mnemonic to help you remember that these 3 things are what perforates the diaphragm at the level of T12? To help you remember this, just remember the rhyme. At T12, it's red, white, and blue. Red for the aorta, white for the thoracic duct, and blue for the azygos vein. What is the mnemonic to help you remember these different structures perforating the diaphragm? The mnemonic is to remember the number of letters at T level. So therefore T8 is vena cava, and that contains 8 letters. T10 is the esophagus, which contains 10 letters, and T12 is the aortic hiatus, which is 12 letters. Another mnemonic is to remember I ate 10 eggs at 12. I is for inferior vena cava, 8 is for the number 8 because of the T8 level, 10 is the T10 level, egg is for esophagus, At is for aorta, and 12 is for the T12 level. What nerve innervates this involuntary muscle, the diaphragm? Diaphragm is innervated by the phrenic nerve, which comes off of C3, C4, C5. Describe how pain from diaphragm is referred. Pain from the diaphragm is referred to the shoulder via C5 and to the trapezius ridges via C3 and C4. What is the mnemonic to help you remember that the diaphragm is innervated by these cervical nerves? The mnemonic is to remember C3, C4, C5 keeps the diaphragm alive. Muscles of respiration. What muscle is used in quiet breathing? We already mentioned that diaphragm, which is an involuntary muscle that is used for inspiration in quiet breathing, and expiration in quiet breathing happens passively. Name all the muscles used for inspiration during exercise. In exercise, the muscles that are used for inspiration includes the external intercostals, scalene muscles, and sternocleidomastoid muscle. Name all the muscles useful in expiration during exercise. During exercise, the muscles used for expiration include rectus abdominis, internal and external obliques, transversus abdominis, and internal intercostals. Other than exercise, name some situation in which you would use the accessory muscles for breathing. Other than exercise, you would use these accessory muscles for breathing, such as in conditions of respiratory distress or during active breathing. Lung volumes. What are the 4 different lung volumes? The 4 different lung volumes includes the tidal volume, the inspiratory reserve volume, the expiratory reserve volume, and the residual volume. Describe all the different lung volumes. So when a person is just doing normal inspiration and expiration, this is the quiet breathing. The amount of air that comes into the lung with each quiet inspiration is your tidal volume, and this is around 500 ml. Now, after you do a normal inspiration, you still have the capacity of breathing in more air if you needed to. So the amount of air that can still be breathed in after a normal inspiration is your inspiratory reserve volume. Now, on the other side of the spectrum, after you do a normal expiration, you still have the ability of breathing out more air from your reserve, and this would be the expiratory reserve volume. So this is the amount of air that can still be breathed out after a normal expiration. Now, after you do a maximum expiration, the amount of air you still have left over in your lung would be your residual volume. This is the air you are not able to breathe out because this is the amount of air that will always be in the lungs. So this is the air that is in the lung after maximal expiration. And this residual volume cannot be measured on spirometry. Name the different type of lung capacities. The lung capacities includes the inspiratory capacity, the functional residual capacity, vital capacity, and the total lung capacity. What is inspiratory capacity? Now, as we already mentioned the different lung volumes, this should kind of help you understand the capacities. So the inspiratory capacity is the total amount of air that can be breathed in. So this includes the tidal volume plus the inspiratory reserve volume. So basically this is the maximum inspiration you could do. What is functional residual capacity? Functional residual capacity is the volume in lungs after normal expiration. So this measure includes the expiratory reserve volume and the residual volume. What is vital capacity? Vital capacity is the maximum volume of gas that can be expired after a maximal inspiration. So after you take the longest inspiration, the maximum amount of gas that you are able to expire is your vital capacity. And this is the sum of tidal volume, inspiratory reserve volume, and expiratory reserve volume. What is the total lung capacity? The total lung capacity is the volume of gas present in the lungs after a maximal inspiration. And this is the total of all the volumes, which includes the tidal volume, inspiratory reserve volume, expiratory reserve volume, and the residual volume. What is the mnemonic to help you remember the different lung volumes? The mnemonic is to remember the word liters, and that's L for lungs, I is for inspiratory reserve volume, T is for tidal volume, E is for expiratory reserve volume, and R is for the residual volume. And so the word liters makes perfect sense because all these volumes are also measured in liters. Determination of physiologic dead space. What is physiologic dead space? Physiologic dead space is the volume of air which is inhaled that does not take part in gas exchange. And the reason this could be is because the inspired air remains in the conducting airway, or it reaches alveoli that are not perfused or are poorly perfused. So in other words, not all the air that is breathed in is available for exchange of oxygen and carbon dioxide. So basically, the physiologic dead space is the anatomic dead space, which is the air that remains in the conducting airways, plus the functional dead space. And the functional dead space is the areas of alveoli such as in the apex of a healthy lung, because this area does not take part in gas exchange, and the apex of a healthy lung is the largest contributor of functional dead space. What is the equation of physiologic dead space? The equation of physiologic dead space is denoted here by VD, and VD equals the tidal volume times the arterial PCO2 minus the expired air PCO2 over the arterial PCO2. What is the mnemonic to help you remember the equation of this physiologic dead space? The mnemonic, just remember taco, paco, peco, and paco again. So that's taco, paco, peco, paco, and this refers to the order of variables in this equation. Lung and chest wall. Describe the physiologic state of the lung and chest wall at FRC or at resting stage. So at FRC, you have just completed a normal expiration. At this point, there is the tendency for the lungs to collapse inward and for the chest wall to spring outward. So at FRC, the inward pull of the lung is balanced by the outward pull of the chest wall, and the system pressure at this point is atmospheric. Also, at FRC, the airway and alveolar pressures are at 0. The intrapleural pressures at this point are negative, and the reason for this negative intrapleural pressure is to keep the airways open and to prevent pneumothorax. What is pulmonary compliance? Pulmonary compliance is the change in lung volume for a given change in pressure. What does low pulmonary compliance indicate? Low pulmonary compliance indicates a stiff lung, which means extra work for the lung to bring in normal volume of air. What are some conditions that would lead to decrease in lung compliance? The conditions that would lead to decrease in lung compliance include pulmonary fibrosis, pneumonia, and pulmonary edema. What does an increase in lung compliance indicate? An increase in lung compliance indicates that the elastic tissue of the lung has been damaged. Name some situations that would lead to an increase in compliance. An increase in compliance will happen in emphysema and with normal aging. Briefly, describe the picture on your screen. The picture on your screen just basically mentions everything we have already talked about, which means that at FRC, there is a tendency for the lung to collapse inward and the chest wall to spring outward, and that center point is the atmospheric pressure. What is hemoglobin? Hemoglobin is an iron-containing oxygen transport metalloprotein in the red blood cells. Its function is to carry oxygen from the respiratory organs to the rest of the body. Describe the structure of hemoglobin. Hemoglobin is a quaternary structure, and it's composed of 4 polypeptide subunits, which are the 2 alpha and 2 beta subunits. What are the 2 forms of hemoglobin? The 2 forms of hemoglobin is the T form or the taut form. You could also think of this as the tense form, and the R form, which is the relaxed form. Describe these 2 forms' affinity to oxygen. Taut form or the T form has low affinity for oxygen, whereas the relaxed form has a high affinity for oxygen. And this high affinity is high by about 300 times. What is the mnemonic to help you remember the taut form and the relaxed form? The mnemonic is to remember that the taut form is found in tissues because of the low affinity for oxygen. So remember T for taut and T for tissue, whereas the relaxed form is found in the respiratory system, and R for relaxed and R for respiratory. One additional thing to note about hemoglobin that we have also mentioned in the pharmacology chapter is that hemoglobin has cooperative kinetics and therefore has a sigmoid curve instead of having a hyperbolic enzymatic reaction curve. Describe how loading and unloading of oxygen on hemoglobin occurs. Oxygen is loaded on hemoglobin in the respiratory system. In the respiratory system, you have high pH, low carbon dioxide, and low concentration of 2,3-bisphosphoglycerate. All these things are what favors the relaxed form of hemoglobin. So in the respiratory system, there is relaxed form of hemoglobin, so this area has a high affinity for oxygen, so therefore oxygen is going to be able to load onto the hemoglobin and will now travel to the tissues. Once the hemoglobin with the oxygen gets to the tissue, at the tissue there is low pH, high carbon dioxide, and high concentration of 2,3-bisphosphoglycerate, and these are all the things that favor the tau form of hemoglobin. So when the relaxed form converts into the tau form, this is going to lead to low oxygen affinity and therefore leading to the unloading of oxygen at the tissues. Describe the properties of fetal hemoglobin. Fetal hemoglobin has 2 alpha and 2 gamma subunits, which has a lower affinity for the 2,3-bisphosphoglycerate than the adult hemoglobin, and therefore there is a higher affinity for oxygen. Hemoglobin modifications. What happens if hemoglobin or hemoglobin binding areas are modified? When hemoglobin is modified, this can lead to tissue hypoxia from decrease in oxygen saturation or decrease in the oxygen content. So basically when hemoglobin is modified, it can no longer take sufficient oxygen to its end tissue and therefore leading to tissue hypoxia. What is methemoglobin? Methemoglobin is when you have an oxidized form of hemoglobin. So in this condition, the iron that is normally in the ferrous state or Fe2+ state is converted into the ferric form or Fe3+, and this has a decreased affinity for oxygen. So this oxidized form of hemoglobin will not be able to bind to that oxygen readily and therefore decreasing in the affinity for oxygen, but there is going to be an increased affinity for cyanide. Name some drugs that can lead to formation of methemoglobin. Methemoglobin can occur when there is poisoning with drugs such as nitrites and dapsone. How can methemoglobinemia be treated? Methemoglobinemia can be treated with methylene blue. Describe how methemoglobin can be useful in cyanide poisoning. As we mentioned a few minutes ago that when the ferrous form of hemoglobin is converted into the ferric form or Fe3+ form, this has an increased affinity for cyanide. So therefore, if you have cyanide poisoning, you can just give drugs such as nitrites, which will oxidize the hemoglobin to form that ferric form, and that ferric form will bind to the cyanide. Now once you have cyanide bound to methemoglobin, you have to now get it out of the system. So therefore you give a drug such as thiosulfate, which will bind to the cyanide methemoglobin complex forming thiocyanate, and this will be renally excreted. What is carboxyhemoglobin? Carboxyhemoglobin is a form of hemoglobin that is bound to carbon monoxide in place of oxygen, and this happens when you have carbon monoxide poisoning. Describe the type of affinity that carbon monoxide has for hemoglobin. Carbon monoxide has 200 times greater affinity to hemoglobin than does oxygen. So therefore, if you have carbon monoxide poisoning, then this carbon monoxide will bind to hemoglobin instead of that oxygen being able to bind, so therefore leading to a decreased oxygen binding capacity on that hemoglobin and eventually leading to decrease in oxygen unloading at the tissues. How can you differentiate between methemoglobinemia versus carbon monoxide poisoning? The way you differentiate both of these is because in methemoglobinemia, the person becomes more cyanotic, versus carbon monoxide poisoning in which the blood turns really red. How do you treat carbon monoxide poisoning? Carbon monoxide poisoning can be treated with hyperbaric oxygen because you're just trying to get that carbon monoxide pushed off from the hemoglobin and instead have oxygen attached to it. Therefore, by giving hyperbaric oxygen, you can achieve this. Oxygen-hemoglobin dissociation curve. Why does the oxygen-hemoglobin dissociation curve have a sigmoidal shape? The reason for the sigmoidal shape is due to the positive cooperativity. And the reason for this is because the tetrameric hemoglobin molecules can bind 4 oxygen molecules and has a higher affinity for each subsequent oxygen molecule bound, and therefore shows that sigmoidal curve. One additional thing to note here is that myoglobin is monomeric, and thus does not show positive cooperativity and its curve is not sigmoidal. Describe what will cause the oxygen-hemoglobin dissociation curve to shift to the right. The curve shifts to the right when you have decreased affinity of hemoglobin for oxygen, and when this happens, it facilitates unloading of oxygen to the tissues. What are all the factors that will cause the right shift of the oxygen-hemoglobin dissociation curve? So as we said, the right shift of oxygen-hemoglobin dissociation curve happens when your tissue has a greater need for oxygen. So the oxygen need for tissue increases when you have a high amount of carbon dioxide in a tissue, also if there is high amount of 2,3-bisphosphoglycerate, Also, when you're exercising, your body needs more oxygen if your tissues become more acidic or if you're at a higher altitude. And also with high temperature, your body all requires increased amount of oxygen needing to be delivered. Now, to understand this a bit better, let's think about when you're exercising. Now, when you're exercising and working out a specific muscle, that muscle becomes hot. It also has a higher amount of carbon dioxide there, and it also becomes acidic. So it makes sense that when you're exercising, these are the signals that your body will recognize and cause that right shift of the dissociation curve to deliver more oxygen to that area. What is the mnemonic to help you remember all the factors that will cause the oxygen hemoglobin dissociation curve to shift to the right? The mnemonic is to remember CB. The C stands for increase in carbon dioxide, B stands for bisphosphoglycerate, so that's for 2,3-bisphosphoglycerate, E is for increase in exercise, A is for the tissue being more acidic or increase in altitude, and the T is for the increase in temperature. So these are all the signals that will cause delivery of oxygen to the tissues. Now, one additional thing I would like to mention here is that we mentioned all these factors earlier in the chapter when we said that all these factors are what stabilizes the T form or the taut form of hemoglobin, and that taut form of hemoglobin is what unloads the oxygen at the tissues. What does the right shift in the oxygen hemoglobin dissociation curve indicate? A right shift indicates there is an increased affinity for hemoglobin for oxygen. Therefore, there is a decrease in unloading of oxygen to the tissues. What are all the factors that would cause the left shift of oxygen hemoglobin dissociation curve? The left shift occurs when the hemoglobin does not want to let go of the oxygen that it has, and this happens when you have a decrease in the amount of carbon dioxide in the tissue, because if you have low amount of carbon dioxide in the tissue, that means you don't need oxygen, so therefore it's not going to get unloaded there. Also, if you're resting or are hypothermic, you would need more oxygen. So basically anything that just leads to a higher affinity for hemoglobin for oxygen will cause the shift to happen to the left. One additional side note that I would like to mention here is we talked about fetal hemoglobin and how it has a higher affinity for oxygen than adult hemoglobin. So therefore fetal hemoglobin also causes the dissociation curve to shift to the left. Describe what happens to the oxygen hemoglobin dissociation curve in case of carbon monoxide poisoning. In carbon monoxide poisoning, the hemoglobin has a decreased oxygen binding capacity because the spaces where oxygen would normally bind has been taken over by carbon monoxide. So therefore there is a decrease in that oxygen binding capacity, which makes it seem like there is not enough hemoglobin available for the oxygen to bind, and therefore this causes a left shift of the oxygen hemoglobin dissociation curve. Also, with carbon monoxide poisoning, the hemoglobin is bound to carbon monoxide instead of oxygen. So because of this, the delivery of oxygen to the tissue is also decreased. Alright, now we're going to talk about the pulmonary circulation. Now before we move on in the book, let's just quickly talk about the picture you see on your screen. This explains the pulmonary circulation and the systemic circulation. So let's just briefly take a look at this. Now let's start with the systemic circulation, and let's start in the left atrium. Now, as we know, and most people will already know the systemic circulation, the way it works is the blood comes in. This is all oxygenated blood. It comes in from the lung, and it comes into the left atrium, goes into the left ventricle, and out through your aorta, and it supplies your entire body. So the blood goes to all the tissues in your body from that aorta. So it goes to your brain, it goes to your hands, arms, legs, and this is all oxygenated blood. So all this blood is going to the body to give it sufficient amount of oxygen. Now once the body, for example, the brain, the hands, the legs, once it uses that oxygenated blood, now it has to return the blood back to the lungs for it to get oxygenated again. So the way it does that is now the deoxygenated blood comes in to the inferior vena cava and the superior vena cava. It meets in the right atrium, goes to the right ventricle, out through your pulmonary arteries, and they're called pulmonary arteries even though they have deoxygenated blood is because they're taking the blood to the lungs. So pulmonary artery will take the blood to your lungs where it will get oxygenated again and it will come back to the heart at the left atrium. So this is how the cycle works. Oxygenated blood goes throughout the entire body, comes back as deoxygenated, gets pumped to your lungs, and that there it again gets oxygenated. So these are the two different circulations. It's the pulmonary circulation and the systemic circulation. The pulmonary circulation is the part where the heart is pumping the blood from the heart to the lungs. So that's your pulmonary circulation, and the way it goes through your entire body would be the systemic circulation. So basically, looking at this picture, you should be able to understand all those little concepts that will explain the pulmonary and the systemic circulation. Now let's go a bit deeper in understanding the difference in the two circulations. There are a couple of important things to understand when talking about these two different circulations, whereas in systemic circulation, when there is hypoxia, so if a tissue is not getting enough blood, what it'll do is there's going to be vasodilation, and vasodilation allows more blood to go to that area. Alright, so that's simple enough. Now in the lungs, what happens is when there is hypoxia, it's counterproductive for blood to go there, because if that area is hypoxic, it's not going to be able to do justice to reoxygenate that area. Now looking at the pulmonary circulation, you see that the blood that's going to the lungs, it's all deoxygenated blood, right? So if deoxygenated blood is going to areas that does not have oxygen, it does not help getting this blood to get oxygenated, right? So think about it again. Deoxygenated blood is going to an area area of the lungs that does not have oxygen. So deoxygenated blood going to area of the lung that does not have enough oxygen does not make any sense. So what happens is in the lungs there is the opposite thing, where if there is hypoxia, if there is not enough oxygen in certain areas of the lung, the blood will not go there, and instead this area will vasoconstrict, and it will send the blood to an area that actually does have more oxygen. So that's the main difference that should be understood between the two different circulations. Whereas in systemic circulation, there's going to be vasodilation, which allows more blood to go there, so it could perfuse that area. Whereas in the pulmonary circulation, it's not going to allow blood to go to hypoxic areas, and therefore will shunt the blood to more oxygenated areas, so that deoxygenated blood will now be able to get oxygenated. Alright, now we're going to move on to the concept of perfusion limited and diffusion limited. Now looking at the picture on your screen here, you see the picture of an alveolus. You also see a picture of capillaries, which is divided into start, middle, and the end of the capillary, and it's also colored differently. The blue color indicates that this is the deoxygenated blood. The red color indicates it's the oxygenated blood. So deoxygenated blood is what comes in, and it goes out once it gets oxygenated as the oxygenated blood. Now looking at the perfusion limited, you see that oxygen, carbon dioxide, and nitrous oxide all in normal situation is perfusion limited. Now what this means is that, let's say you have 20 mmHg of oxygen. That complete 20 mmHg of oxygen is going to make its way to the capillary. It's going to oxygenate all that deoxygenated blood and sends it out. So in that duration, in that whole length of the pulmonary capillary, that oxygen, it's going to make its way to the capillary, and it's going to oxygenate all that blood that's coming in. So this is perfusion limited. So in this, there is that gas equilibrium that occurs early along the length of the capillary, and that is what you see here in the picture of perfusion limited. So looking at this concept, you could tell that the only way you could have more oxygen going into the capillary is if there is an increase in the blood flow. So if there is more capillary blood flow, there's going to be more oxygen that's going to make its way to the capillary, and eventually leading to more oxygen being supplied to the body. Now the second thing we're going to talk about is the diffusion limited. Now diffusion limited is an abnormal condition that occurs with conditions such as emphysema and fibrosis. So think about a capillary with fibrosis. Now because the wall of the capillary was going to be thickened, it's not going to be easy for that oxygen to simply diffuse through. So therefore the equilibrium does not occur. So if you look at the picture here, you see that if there is 20 mmHg of oxygen, only 10 mmHg of oxygen is actually going to make it through. So in this case, there's not going to be an equilibrium by the time blood reaches the end of the capillary. What is the equation of diffusion? The equation of diffusion is the area of the capillary over the thickness of the capillary times the diffusion constant times P1 minus P2. The diffusion constant times P1 minus P2 is the difference in the partial pressure. What condition would decrease the area in the capillary? The area in the capillary is decreased in emphysema and COPD. What condition causes the increase of thickness in the capillary? Increase in thickness of the capillary occurs in pulmonary fibrosis. So therefore, in both pulmonary fibrosis and in emphysema, you would have a decrease in diffusion. What happens when you have pulmonary hypertension? If you have long-term pulmonary hypertension, This can lead to cor pulmonale, which is the right-sided heart failure. What are the consequences of right-sided heart failure? With the right-sided heart failure, the right side of the heart is not able to adequately pump the blood out, therefore leads to a backup of blood, and this you could see by signs such as jugular venous distension, edema, and hepatomegaly. Pulmonary hypertension. What is the normal pulmonary artery pressure? The normal pulmonary artery pressure is between 10 and 14 millimeters of mercury. What would the pulmonary artery pressure be in pulmonary hypertension? In pulmonary hypertension, the pulmonary artery pressure can become greater than 25 millimeters of mercury or greater than 35 millimeters of mercury during exercise. What can be the consequence of pulmonary hypertension? Pulmonary hypertension will result in atherosclerosis, medial hypertrophy, and intimal fibrosis of the pulmonary artery. We already mentioned earlier in the chapter that long-standing pulmonary hypertension can lead to right-sided heart failure. What problem can lead to primary pulmonary hypertension? Primary pulmonary hypertension can result due to inactivating mutation in the BMPR2 gene, and the function of this gene normally is to inhibit vascular smooth muscle proliferation. And so when that gene is mutated, it leads to proliferation of the vascular smooth muscles, leading to primary pulmonary hypertension. One thing to also note about primary pulmonary hypertension is that there is good prognosis for this. Name all the conditions that can lead to secondary pulmonary hypertension. Pulmonary hypertension can occur due to some underlying conditions such as COPD, in which there would be destruction of the lung parenchyma, leading to an increased pressure in the pulmonary arteries, and therefore leading to pulmonary hypertension. Also, mitral stenosis would increase the resistance and therefore increasing the pressure in the pulmonary arteries, leading to pulmonary hypertension. Also, recurrent thromboembolies, which would decrease the cross-sectional area of the pulmonary vascular bed, also leading to that increased pressure in the pulmonary artery, leading to pulmonary hypertension. Autoimmune diseases such as systemic sclerosis can also lead to pulmonary hypertension because there is inflammation in systemic sclerosis, which causes intimal fibrosis and medial hypertrophy. Sleep apnea and high altitude can also lead to pulmonary hypertension because there is continuous hypoxic vasoconstriction that occurs. And finally, left to right shunt can also lead to pulmonary hypertension because the left side of the heart will keep moving the blood to the right side, causing a continuous increase in the pressure in the right side of the heart, leading to pulmonary hypertension. So again, to sum all of that up, COPD, mitral stenosis, recurrent thromboembolies, autoimmune disease, left to right shunt, sleep apnea, and living at high altitudes can all contribute to pulmonary hypertension. Describe the disease progression seen with pulmonary hypertension. Pulmonary hypertension will start off as respiratory distress. It will eventually become severe respiratory distress, then leading to cyanosis and right ventricular hypertrophy, and this eventually leads to death from decompensated cor pulmonale or right-sided heart failure. Pulmonary vascular resistance. When talking about the pulmonary vascular resistance, you always want to refer back to the cardiovascular chapter when we talked about resistance, pressure, and flow, and there are similar concepts that are highlighted here. What is the equation of pulmonary vascular resistance? The equation for pulmonary vascular resistance is the pressure in the pulmonary artery minus the pulmonary wedge pressure over the cardiac output. As we recall from the cardiovascular chapter, that pulmonary capillary wedge pressure is a good approximation of the left atrial pressure, and the normal pulmonary capillary wedge pressure is 12. Also, a few additional equations to help you remember resistance is when thinking about resistance, always think that resistance is the pressure gradient over flow. So the pressure gradient in pulmonary vascular resistance would be the pulmonary artery pressure minus the pulmonary capillary wedge pressure. And Q is the cardiac output. Oxygen content of blood. How do you determine the oxygen content of the blood? Oxygen content of blood is the oxygen binding capacity times the percent saturation plus the dissolved oxygen. So to remember this, just remember that oxygen in the blood only exists in two forms. It's either bound to hemoglobin or is dissolved. How much oxygen can 1 gram of hemoglobin bind? 1 gram of hemoglobin can bind 1.34 milliliters of oxygen. What is the normal amount of hemoglobin in the blood? The normal amount of hemoglobin in the blood is around 15 grams per deciliter. So based on this information, what would the oxygen binding capacity be? Based on this information, the oxygen binding capacity would be 15 times 1.34, which comes out to roughly 20.1 milliliters of oxygen per deciliter. One additional thing to note here is that cyanosis can result if deoxygenated hemoglobin is greater than 5 grams per deciliter. What effects does decreasing hemoglobin have on oxygen? Decrease in the amount of hemoglobin also leads to decrease in the oxygen content of the arterial blood, but the saturation of oxygen and the arterial PO2 are not affected. What is the equation to calculate the oxygen delivery to tissue? Oxygen delivery to tissue can be determined by the cardiac output times the oxygen content of blood. Alveolar gas equation. What does the alveolar gas equation calculate? The alveolar gas equation calculates the alveolar arterial oxygen gradient, also known as AA gradient. What is alveolar gas equation? Alveolar gas equation is the alveolar PO2, and this equals PO2 in the inspired air minus the arterial PCO2 over the respiratory quotient, and respiratory quotient is the carbon dioxide produced over oxygen consumed. What is the normal approximation of PiO2 or the PO2 in inspired air? The PiO2 normally is 150. What is the normal respiratory quotient? The normal respiratory quotient is 0.8. What is the normal range of the AA gradient? The normal range of AA gradient is 10 to 15 millimeters of mercury. Name some causes that can increase the AA gradient. An increase in the AA gradient can be due to hypoxemia, which may be caused by right-to-left shunting, VQ mismatch, and fibrosis. We already mentioned that fibrosis of the vessel walls can cause impaired diffusion, so it makes sense that it would lead to an increase in the alveolar arterial oxygen gradient. Oxygen deprivation. What is hypoxemia? Hypoxemia is when you have a decrease in the partial pressure of the arterial oxygen content. This basically just means that there's not enough oxygen inside the blood and blood vessels. Name some conditions in which you would have a normal AA gradient but still hypoxemia. You would have normal AA gradient hypoxemia when the problem is the oxygen that is entering the lungs is not sufficient. So in this, the problem is before the oxygen has to cross the AA gradient. And conditions that can lead to normal AA gradient hypoxemia include high altitude, where there's not enough oxygen, and hypoventilation, where you're not intaking enough oxygen. Name some conditions that would lead to hypoxemia with an increase in the AA gradient. An increase in the AA gradient does lead to hypoxemia, as we mentioned earlier in the chapter, and these causes include right-to-left shunt, such as with tetralogy of Fallot, VQ mismatch, and diffusion limitations, such as fibrosis. What is hypoxia? Hypoxia is the problem in oxygen delivery to the tissue. What are some causes of hypoxia? Hypoxia can occur due to decrease in cardiac output. When the heart is not pumping sufficient blood, it's not going to allow the blood to get to where it needs to go, therefore leading to hypoxia. Hypoxemia can also lead to hypoxia because if there is not enough oxygen in the blood, whatever blood that's going to get to the tissue is not going to also have enough oxygen, therefore leading to hypoxia. Anemia can lead to hypoxia because if there's not enough red blood cells, this again will also lead to hypoxia because there's not going to be enough oxygen that's coming on those red blood cells to the tissues. Also, carbon monoxide poisoning will also lead to hypoxia because there is sufficient amount of blood that will be going to tissues, but it's not going to have oxygen. It's actually going to have carbon monoxide. So therefore, it can't use it, and therefore leading to hypoxia of the tissue. What is ischemia? Ischemia is the loss of blood flow to the tissue. How does ischemia lead to oxygen deprivation? Ischemia caused by an embolus or a clot will impede the arterial flow. Therefore, the blood is not able to get to its tissue, leading to oxygen deprivation. Also, a reduction in the venous drainage can also lead to oxygen deprivation because if blood can't exit the capillary bed, then that means that no blood can enter it either, hence leading to oxygen deprivation. VQ mismatch. What does VQ stand for? V stands for ventilation and Q stands for perfusion. Ideally, ventilation is matched to perfusion in order for adequate gas exchange to occur. Therefore, in ideal situation, the VQ ratio would be 1. What is the VQ ratio in an average individual? An average individual has 4 liters of ventilation for 5 liters of blood flow. Therefore, their VQ ratio is 0.8. Describe the ventilation-perfusion ratios in different parts of the lung. Different zones of the lung have different ventilation-perfusion ratios. The reason for this is due to gravity. So, in the apex of the lung, there is higher ventilation and low perfusion. This leads to a higher VQ mismatch, and this is why it's said that there is wasted ventilation in the apex of the lung. The base of the lung, due to gravity, will have a higher perfusion and a lower ventilation. The reason for this is because blood weighs more than air does. So therefore, the base will have higher perfusion and lower ventilation. Therefore, the VQ mismatch is going to be lower. And because there is high perfusion and low ventilation, this is said to have wasted perfusion. So even though with these higher and lower ratios, both ventilation and perfusion are greater at the base of the lung than at the apex of the lung. What situation will cause the VQ mismatch at the apex of the lung to be closest to 1? VQ mismatch at the apex of the lung gets the closest to 1 during exercise, because in exercise there is going to be an increase in cardiac output, and this causes vasodilation in the capillaries of the apex, leading to a higher perfusion. Therefore, the ventilation-perfusion ratio is closest to 1. Why do some organisms prefer the apex of the lung? As we mentioned, the apex of the lung has high oxygen content because it has a higher ventilation-perfusion ratio. Therefore, certain organisms such as TB will prefer this area. When does ventilation-perfusion ratio equal 0? Ventilation-perfusion ratio equals 0 if you have no ventilation. So it does not matter how much perfusion you have, even if you have 100% perfusion. If you divide 0 by 100, your answer is 0. So your ventilation-perfusion ratio would be 0 in cases of airway obstruction where you're not able to breathe in air. When does ventilation-perfusion ratio approach infinity? Your ventilation-perfusion ratio approaches infinity if you have normal ventilation, but you have a blockade in your perfusion. This would sort of be like dividing 100 by 0, and you can't divide by 0, so it would be approaching infinity. Name a condition that would lead to this VQ mismatch approaching infinity. VQ mismatch approaches infinity when you have some sort of blockade in the blood flow to the lung, and this happens with pulmonary embolism. Carbon dioxide transport. What are the 3 different forms that carbon dioxide is transported from the tissue to the lungs? Carbon dioxide is transported from tissues to lungs as bicarbonate, which happens in 90% of the cases. Carbon dioxide can also be transported as carbaminohemoglobin, which happens in 5% of the cases. And in this, carbon dioxide is bound to hemoglobin at the N-terminus of the globin chain, not heme. And in this way, after the oxygen unloading has occurred, the taut form of hemoglobin will bind the carbon dioxide and transport it to the lung. And the third form in how carbon dioxide is transported from the tissue to the lung is as dissolved carbon dioxide, which also happens in 5% of the cases. So to summarize all this, it's transported as either bicarbonate, as carbaminohemoglobin, or as dissolved carbon dioxide. What does the Haldane effect describe? Haldane effect describes how carbon dioxide is released from the red blood cells. Now let me explain how this happens. Now as we already know, oxygen has to bind to hemoglobin and then it gets transported to tissues. But when oxygen binds to hemoglobin, there is dissociation of hydrogen ions. These hydrogen ions that were released from hemoglobin will now bind to bicarbonate that's in the red blood cell. And this combination will form carbonic acid. Then this carbonic acid, with the help of the enzyme carbonic anhydrase, turn into carbon dioxide and water. This carbon dioxide and water is now freely able to cross across cell membrane. So basically, the effect of all of this was that when originally the oxygen bound to hemoglobin is what got that hydrogen release, and that hydrogen release eventually caused formation of carbon dioxide and water to freely cross across cell membrane and eventually make it all the way up to the alveoli and then finally exhaled. So to summarize the Haldane effect once again, when oxygenation of hemoglobin occurs, there is dissociation of hydrogen from hemoglobin. This will get the carbon dioxide formation process started, and eventually this carbon dioxide is going to be released from the red blood cells and eventually exhaled. What is the Bohr effect? Bohr effect is something that goes on in the peripheral tissue. In this, when the tissue is requiring more oxygen, there is going to be a high amount of carbon dioxide and hydrogen in this area, signaling that it requires more oxygen. Because of this signaling, hemoglobin is going to come through with the oxygen and unload the oxygen for it to be uptaken by the tissue. And that's basically what Bohr effect is. So remember, the Haldane effect is to get carbon dioxide out to the environment, whereas the Bohr effect is to get oxygen into the tissue. Response to high altitude. Describe the physiologic response to high altitude. At high altitude, there is decrease in the oxygen content. This leads to increase in ventilation. And if a person is at higher altitudes for a longer period of time, the body will now start adapting to this, and one of the things it will do is increase the production of erythropoietin to increase the hematocrit and hemoglobin content. And this is the body's response to chronic hypoxia. The body will also increase the production of 2,3-bisphosphoglycerate, and as we mentioned earlier in this chapter, that 2,3-bisphosphoglycerate decreases the affinity of hemoglobin for oxygen, and therefore allowing the T form or the taut form of hemoglobin to unload oxygen to the tissues. And in this way, there is more oxygen getting to the tissues. Also, with chronic hypoxia, there is also cellular changes that occur, such as increase in mitochondria and mitochondrial enzymes, and this is helpful in increasing the efficacy of cellular oxidation. With chronic hyperventilation, there is also respiratory alkalosis that develops. The body will try to compensate for this by renally excreting bicarbonate. The reason it's important for the body to excrete bicarbonate is, as we said earlier in this chapter, that 90% of the carbon dioxide in the body is in the form of bicarbonate. So it makes sense to not have too much carbon dioxide when you're already low on oxygen. And lastly, with chronic hypoxia, you're also putting a lot of pressure on your pulmonary artery because it's continuously going to be vasoconstricting, and therefore this can eventually lead to right ventricular hypertrophy and pulmonary hypertension. Response to exercise. Describe all the physiologic changes that occurs in the body in response to exercise. In exercise, there is an increase in oxygen consumption and increase in carbon dioxide production. The demand of oxygen is also increased, therefore there would be an increase in ventilation to meet this oxygen demand. Now, as we mentioned earlier in the chapter, that the capillaries that are located at the apex of the lungs will dilate. And the reason they're dilating is because they want to allow more perfusion to happen. So in normal condition, there is already high ventilation in the apex of the lung. So if the perfusion also increases, the ventilation-perfusion ratio becomes more close to 1. And overall, the VQ ratio from apex to the base becomes more uniform. During exercise, there is an increase in cardiac output, which has to also be met by the pulmonary blood flow, so there would also be an increase in the pulmonary blood flow. Also, as we know from biochemistry, that during exercise there is formation of lactic acid. This lactic acid production will lead to a decrease in pH of the body. So these are all the physiologic changes that occurs in response to exercise. What is deep vein thrombosis? Deep vein thrombosis is formation of a blood clot, also known as a thrombus, in the deep vein, which are predominantly in the legs. What is the Virchow's triad that predisposes you to getting deep vein thrombosis? Deep vein thrombosis occurs if you have any of these predisposing conditions, such as blood stasis, in which the blood is not moving properly, so therefore the blood is sitting still for a longer period of time. This can lead to clot formation. Also, if you have a hypercoagulability condition, such as defect in the coagulation cascade protein, most commonly factor V laden. So in this condition, you are more likely to form clots in your deep veins, therefore leading to deep vein thrombosis. And lastly, if you have endothelial damage, this would lead to exposing of the collagen, and that can trigger clotting cascade. So again, to summarize this Virchow's triad that leads to venous thrombosis, remember decreased blood flow, which is the venous stasis, also increased tendency to clot, hypercoagulability, and blood vessel wall damage, which can all lead to this deep vein thrombosis. How does a clot formed in the deep veins of the legs lead to pulmonary embolism? A clot that has been formed in the deep veins of the legs can break off from the site of origin and travel in the bloodstream, eventually making its way to the lung, where it can lodge and cause pulmonary embolus. Describe the Hohmann sign seen with deep vein thrombosis. Hohmann sign seen in deep vein thrombosis is the dorsiflexion of the foot, which leads to calf pain. What drug is used in the acute management and prevention of deep vein thrombosis? Heparin is used for the prevention and acute management for deep vein thrombosis. What drug is used in the long-term prevention of deep vein thrombosis and its reoccurrence? The drug used for long-term prevention of deep vein thrombosis is warfarin. Pulmonary embolism. What is pulmonary embolism? Pulmonary embolism is a blockade of the main artery of the lung or one of its branches. by a substance that has traveled from somewhere else in the body through the bloodstream. Name some types of pulmonary embolism. Pulmonary embolism can be caused by fat, air, thrombus, bacteria, amniotic fluid, and tumor. What is the mnemonic to help you remember these types of pulmonary embolism? The mnemonic is to remember that a embolus moves like a fat bat. So that's F for fat, A for air, T for thrombus, B for bacteria, A for amniotic fluid, and T for tumor. So fat bat. How can fat emboli form? A fat emboli can form after long bone fractures and after liposuction procedure. What is the classic triad observed with fat embolism? The classic triad of fat embolism will lead to hypoxemia, neurologic abnormalities, and petechial rash. What problems can be caused by amniotic fluid emboli? Amniotic fluid emboli can lead to disseminated intravascular coagulation, in which there is a widespread activation of the clotting cascade, which can lead to bleeding, bruising, and kidney failure. What are all the nonspecific signs and symptoms associated with pulmonary embolism? The signs and symptoms of pulmonary embolism include sudden onset of dyspnea, chest pain, and tachypnea. One additional thing to note about pulmonary embolism is that if you have a large embolus, such as the saddle embolus in the pulmonary artery, this can cause sudden death. Where do 95% of all pulmonary emboli arise from? 95% of pulmonary emboli arise from deep leg veins, causing that deep vein thrombosis, and this can commonly occur if a person has long-term immobility of their legs. What is the imaging test of choice in pulmonary embolism? The imaging test of choice in pulmonary embolism is CT pulmonary angiography. Obstructive lung disease. What is obstructive lung disease? Obstructive lung disease is a category of respiratory disease categorized by airway obstruction. So because in this there is obstruction of the airflow, this results in air trapping within the lungs. What happens to the forced vital capacity and the residual volume in obstructive lung disease? In obstructive lung disease, because there is air trapping within the lungs, it makes sense that the residual volume would increase, because residual volume is the air that is left in the lung after maximal expiration. So it makes sense that if you have air trapped within the lungs and it's not able to be expired, it makes sense that the residual volume would increase. We also know that the residual volume and the vital capacity makes the total lung capacity, so if you have an increase in the residual volume, it makes sense that there would be a decrease in the vital capacity. So to summarize that, with obstructive lung disease, there is going to be an increase in the residual volume, or RV, and a decrease in the forced vital capacity, or FVC. What does FEV1 stand for? FEV1 stands for forced expiratory volume in 1 second. Describe what happens to the FEV1 and FVC ratio. By looking at the picture on your screen, we already mentioned that there would be a decrease in FVC, so it also makes sense that there would be a decrease in the forced expiratory volume in 1 second, and therefore you would have a decrease in the FEV1-FVC ratio, which is the hallmark finding observed in obstructive lung disease. Describe what happens to the ventilation and perfusion in obstructive lung disease. In obstructive lung disease, because there is a decrease in the vital capacity, this means that there is going to be a decrease in ventilation as well. But perfusion would not be affected, and therefore, comparing to ventilation, the perfusion would be higher, and this would lead to the VQ mismatch. What is chronic bronchitis? Chronic bronchitis is a chronic inflammation of the bronchi, which is the medium-sized airway of the lung. It is generally considered to be one of the two forms of chronic obstructive pulmonary disease, or COPD, and the other being emphysema. Describe what happens to the bronchi in chronic bronchitis. In chronic bronchitis, there is hypertrophy of mucus-secreting glands in the bronchi, which would lead to an increased mucus production as well as inflammation. So this is basically why there is obstruction in the airway. Also, one thing to mention here is that the Reed index would be greater than 50%, and this Reed index is what measures the thickness of the gland layer over the total thickness of the bronchial wall. What clinical findings are observed with chronic bronchitis? In chronic bronchitis, there is productive cough for more than 3 months per year for 2 years. You would also observe wheezing, crackle, cyanosis, which is the blueness, and this happens due to early onset hypoxemia, due to shunting, late onset dyspnea, and signs of right-sided heart failure, and this is what's going to give them that bloated presentation. What is the mnemonic to help you remember chronic bronchitis? The mnemonic to help you remember chronic bronchitis, just remember blue bloater. These patients will appear blue and bloated. The reason they're blue is because of the cyanosis, and bloated because of signs of right heart failure. What is emphysema? Emphysema is the destruction of the alveolar wall, which leads to the enlargement of the alveolar air spaces and therefore a decrease in recoil. So basically in this condition, the person has a very high lung compliance, and that's due to the poor elastic recoil, so they have no problems inflating the lung but have extreme difficulties exhaling the air. What is centriacinar emphysema associated with? Centriacinar emphysema is associated with smoking. What is panacinar emphysema associated with? Panacinar emphysema is associated with alpha-1 antitrypsin deficiency. So these people actually have an enzyme deficiency which is leading to that emphysema. So these are usually non-smokers, younger individuals, and they also have liver cirrhosis due to that enzyme deficiency. What enzyme activity is elevated in emphysema? In emphysema, you see elevation of the elastase activity, and elastase is what breaks down elastic tissue. This is what causes the destruction of the alveolar wall, leading to decrease in recoil. Describe why emphysema is referred to as pink puffer. Emphysema is referred to as pink puffer because it commonly occurs in smokers. Also, because of the decrease in recoil, the person has to work hard to exhale, so they will exhale through pursed lips, which will increase airway pressure and preventing airway collapse during respiration. So this is why, because they have to work so hard to exhale, they turn pink when they're trying to breathe out. What is asthma? Asthma is bronchial hyperresponsiveness, which causes reversible bronchoconstriction. So basically in asthma, there are going to be some triggers that will cause bronchial hyperresponsiveness, and this will cause bronchoconstriction. What are some triggers that can cause the bronchoconstriction seen in asthma? The triggers include viral upper respiratory tract infections, allergens, and stress. What are some diagnostic findings observed with asthma? In asthma, you see smooth muscle hypertrophy, Cushman spirals, and Charcot-Leyden crystals. What are Cushman spirals? Cushman spiral is shed epithelium that forms the mucus plug. This is what has that corkscrew-like appearance. What are Charcot-Leyden crystals? Charcot-Leyden crystals are crystals that are formed from the breakdown of eosinophils. This is seen in allergic conditions such as asthma, as well as in some parasitic infections. What is the diagnostic test for asthma? The diagnostic test for asthma is the methacholine challenge test. What are some signs and symptoms observed with asthma? In asthma, there is cough, wheezing, tachypnea, dyspnea, hypoxemia, decreased the IE ratio, pulsus paradoxus, and mucus plugging. What is bronchiectasis? Bronchiectasis is a disease state defined by localized, irreversible dilation of part of the bronchial tree caused by destruction of muscle and elastic tissue. So basically, this condition leads to a permanent dilation of the airways, and this would lead to purulent sputum, recurrent infections, and hemoptysis, which is coughing up blood. What are all the causes of bronchiectasis? Bronchiectasis happens due to chronic necrotizing infections of the bronchi, which can happen due to staph and Klebsiella. Also, it's associated with bronchial obstruction, poor ciliary motility, which happens in smoking, and this leads to not able to cough up mucus. Also, Courtagner syndrome, cystic fibrosis, and allergic bronchopulmonary aspergillosis. So basically, anything that can lead to inflammation of the airways can lead to bronchiectasis. What is restrictive lung disease? Restrictive lung disease is a category of extrapulmonary, pleural, and parenchymal respiratory diseases that restrict lung expansion. Restrictive lung diseases would then lead to decreased lung volume, increased work on breathing, and inadequate ventilation and/or oxygenation. So basically, in restrictive lung disease, the patient does not have any problems emptying their lungs, but because of restrictions on the lungs, they just have less lung volume. So to summarize that once again, restrictive lung disease is a restricted lung expansion that causes a decrease in lung volume. Therefore, there's going to be a decrease in the forced vital capacity, and there is going to be a decrease in total lung capacity. Describe the pulmonary function test observed in restrictive lung disease. The pulmonary function test is going to show FEV1 and FVC ratio of more than 80%, which is sort of normal, and the reason for this is because patients don't have a problem emptying their lungs, they just have less in their lungs due to the restrictions. What are the two subclassifications of restrictive lung disease? Restrictive lung disease can be further subdivided into extrinsic and intrinsic type. Extrinsic type is commonly due to poor breathing mechanism, which has an extrapulmonary cause with peripheral hypoventilation and a normal alveolar arterial gradient. The intrinsic type, on the other hand, is due to interstitial lung diseases. It has a pulmonary cause, it leads to lower diffusion capacity, and this commonly happens due to fibrosis, and therefore there is going to be an increase in the alveolar arterial gradient. Give some examples of poor breathing mechanism that would lead to restrictive lung disease. Restrictive lung disease can happen due to poor muscular effort of breathing, such as in polio and myasthenia gravis. It can also happen due to poor structural apparatus, which causes restriction on the lung, such as with scoliosis and morbid obesity. And morbid obesity is one of the more common causes that leads to restrictive lung disease. Name all the causes of intrinsic restrictive lung disease. The intrinsic causes of restrictive lung disease includes acute respiratory distress syndrome, neonatal respiratory distress syndrome, which is a hyaline membrane disease, pneumoconiosis such as anthracosis, silicosis, and asbestosis. Sarcoidosis can lead to restrictive lung disease, in which there is bilateral hilar lymphadenopathy, non-caseating granulomas, increase in angiotensin-converting enzyme and calcium. Also, idiopathic pulmonary fibrosis can lead to restrictive lung disease. In this, there is a repeated cycle of lung injury followed by wound healing, and this increases collagen deposition. Other intrinsic causes of restrictive lung disease includes Goodpasture syndrome, granulomatosis with polyangiitis, which is also known as Wegener's granulomatosis, Langerhans cell histiocytosis, hypersensitivity pneumonitis, drug toxicities with bleomycin, busulfan, amiodarone, and methotrexate can all lead to restrictive lung disease. What is pneumoconiosis? Pneumoconiosis is a type of restrictive lung disease that occurs due to long-term exposure to foreign substances that leads to change in normal lung parenchyma. Name some different types of pneumoconiosis. Different types of pneumoconiosis include anthracosis, silicosis, and asbestosis. What is anthracosis? Anthracosis is something that occurs in coal miners. This is when coal miners are exposed to coal and its byproducts, which leads to the classic coal miner's lung or the black lung. What part of the lung is affected by anthracosis? Anthracosis affects the upper lobes. What is silicosis? Silicosis, which is also known as grinder's asthma or Potter's rot, is a form of occupational lung disease caused by the inhalation of crystalline silica dust. This is associated with people that work in foundries, sandblasting, and mines. Describe the pathogenesis observed in silicosis. In silicosis, the macrophages will respond to this inhaled silica dust and it will release fibrogenic factors which will cause fibrosis. It is also thought that silica may disrupt phagolysosomes and impair macrophages, which increases the susceptibility to TB. Silicosis is also known to increase the risk of bronchogenic carcinoma. What part of the lung does silicosis primarily affect? Silicosis primarily affects the upper lobes of the lung. What morphologic finding is observed in silicosis? In silicosis, you would see the eggshell calcification of hilar lymph nodes. What is asbestosis? Asbestosis is a lung disease that occurs from breathing in asbestos fibers. It occurs in people that work in shipbuilding, roofing, and plumbing. Describe the pathogenesis observed in asbestosis. In asbestosis, there is scarring of the lung tissue that occurs from inhalation of asbestos fibers. There is also ivory-white calcified pleural plaques, which are pathognomic of asbestos exposure, but are not precancerous. So basically, in asbestosis, once the asbestos fibers are in the lungs, the macrophages will try to eliminate it, but it's not going to be able to, therefore leading to inflammation and scarring. What types of cancer is asbestosis associated with? Asbestos exposure can lead to an increased incidence of bronchogenic carcinoma and mesothelioma. Describe the morphologic appearance of asbestos fibers. Asbestos fibers are golden brown fusiform rods that resemble dumbbells. So as you can see on the picture on the screen that they do resemble dumbbells. These dumbbell appearing rods are also known as ferruginous bodies. What part of the lung does asbestosis commonly affect? Asbestosis commonly affects the lower lobes of the lung. One additional thing to remember about pneumoconiosis is that with pneumoconiosis, there is an increased risk of cor pulmonale and Kaplan syndrome. And the reason this occurs is because there is an alteration in the person's immune system and the way it responds to foreign material. What is Kaplan syndrome? Kaplan syndrome is basically the combination of rheumatoid arthritis plus pneumoconiosis, and that's why this condition is also called rheumatoid pneumoconiosis. What is neonatal respiratory distress syndrome? Neonatal respiratory distress syndrome is a syndrome in premature infants caused by developmental insufficiency of surfactant production and structural immaturity in the lungs. So basically, in this condition, there is surfactant deficiency, and as we mentioned, surfactant is what decreases the surface tension. So if you have surfactant deficiency, there is going to be an increase in the surface tension, which is going to lead to increased work for breathing, and therefore leading to alveolar collapse. What diagnostic test is indicative of neonatal respiratory distress syndrome? A diagnostic test indicative of neonatal respiratory distress syndrome is lecithin sphingomyelin ratio of under 1.5 in the amniotic fluid. So if it is under 1.5, this is predictive of neonatal respiratory distress syndrome, where if it is over 2, this means that the lungs have fully matured. What are some complications that can arise due to neonatal respiratory distress syndrome? We already mentioned that neonatal respiratory distress syndrome can lead to alveolar collapse, but because there is a persistent low oxygen tension, there is a risk of patent ductus arteriosus. Now, to understand this, we mentioned in the cardiology chapter that you need high oxygen tension after birth to close that PDA. So when you don't have that in neonatal respiratory distress syndrome, it will keep the ductus arteriosus open. Now, to correct the low oxygen tension, if you are to give supplementation of oxygen, this can lead to too much oxygen in the neonate, and that could lead to additional problems such as retinopathy of prematurity and bronchopulmonary dysplasia. What are the risk factors of developing neonatal respiratory distress syndrome? Neonatal respiratory distress syndrome, as we already mentioned, occurs in prematurity. Also, if the mother has diabetes, this can lead to premature delivery. And lastly, cesarean delivery can also lead to this due to the decreased release of fetal glucocorticoids. What are some treatment options to correct neonatal respiratory distress syndrome? The treatment options for neonatal respiratory distress syndrome includes maternal steroids before birth to speed up lung maturity, or you can give artificial surfactant for the infant. What is acute respiratory distress syndrome? Acute respiratory distress syndrome is a life-threatening lung condition that prevents enough oxygen from getting to the lungs and into the bloodstream. What are all the causes that can lead to acute respiratory distress syndrome? Acute respiratory distress syndrome can be caused by trauma, sepsis, shock, gastric aspiration, uremia, acute pancreatitis, or amniotic fluid embolism. Describe the pathogenesis of acute respiratory distress syndrome. In acute respiratory distress syndrome, one of the causes that we just mentioned is going to cause diffuse alveolar damage and increase in alveolar capillary permeability. Now, when there is an increase in the alveolar capillary permeability, there is going to be a leakage of protein-rich material along with neutrophilic substances into the alveoli. This protein-rich material is going to cause the formation of the intra-alveolar hyaline membrane, and the neutrophilic substance is going to cause damage to the alveolar wall. So basically, in acute respiratory distress syndrome, there's going to be high amounts of fluid that will end up getting into the alveoli and cause damage there. Obstructive versus restrictive lung disease. Alright, now we're going to take a look at these three pictures and talk about what's happening. First, you see the normal condition of a lung in which your forced expiration volume in 1 second over forced vital capacity is around 80%. Now we're going to compare this normal condition with obstructive and restrictive lung diseases. Now, when you have an obstructive lung disease, there is going to be higher than normal lung volumes. And the reason for this is due to the air trapping, and therefore we know that when there is higher than normal lung volumes, the residual volume increases. So again, to summarize that, obstructive lung disease has higher lung volume than in normal. There is an increase in total lung capacity, increase in functional residual capacity, and increase in the residual volume. What would the FEV1 over FVC ratio be in obstructive lung disease? In obstructive lung disease, the FEV1 over FVC ratio is going to be under 80%. The reason being, you're not going to be able to do a maximum expiration due to the air trapping. Now next, we're going to talk about restrictive lung disease. We mentioned earlier in the chapter that restrictive lung disease is not a problem emptying the lungs, but there's just less lung volume due to the restriction. What is the FEV1 over FVC ratio observed in restrictive lung disease? The FEV1 over FVC ratio in restrictive lung disease is equal or greater than 80%. The reason it's equal to or greater than normal is because there is no problem expiring the air. The problem is that you just have less amount in the lungs. One thing to note here though, that in both obstructive and restrictive lung disease, the FEV1 and FVC are reduced, but in obstructive lung disease, however, the FEV1 is more dramatically reduced compared to the FVC, and that is why you see that FEV1 over FVC ratio in obstructive lung disease being lower. What is sleep apnea? Sleep apnea is the pauses in breathing during sleep that happens for more than 10 seconds, and this can happen between 5 to 30 times in an hour. Now, because of these pauses in breathing, there is disrupted sleep at night, and this would lead to daytime sleepiness. What is the most common type of sleep apnea? The most common type of sleep apnea is obstructive sleep apnea. What is the difference between central and obstructive sleep apnea? Central sleep apnea is when a person stops breathing at night because the signals in the brain that tell the body to keep breathing don't work properly. So in this condition, there is just no effort made to inhale, whereas in obstructive sleep apnea, an effort is made to breathe, but because of the collapsed upper airways, it can't get air in the lungs. So basically, central sleep apnea is when there is no respiratory effort, whereas in obstructive sleep apnea, there is respiratory effort against airway obstruction. And obstructive sleep apnea is associated with obesity, loud snoring, systemic or pulmonary hypertension, arrhythmias, and possibly sudden death. Name some of the causes that can lead to central sleep apnea. Central sleep apnea can be caused by neurologic problems, drug use, as well as heart or kidney failure. Now, one additional thing to note about sleep apnea is because of these disturbances in breathing, there is hypoxia that can occur, and this would lead to increase in erythropoietin release, and therefore an increase in erythropoiesis is also seen with sleep apnea. What are some treatment options for sleep apnea? Sleep apnea can be treated with CPAP or surgery, and it can also stop after weight loss. Lung physical findings. Now, before we move on to talking about this, let's define some words which will help us understand this section a bit better. So we're going to start off talking about percussion. What is percussion? Percussion is a method of tapping on a surface to determine the underlying structure. It is used in clinical examination of the thorax and abdomen. What does a dull sound in percussion indicate? A dull sound indicates that there is a presence of a solid mass under the surface. What does a hyperresonant sound in percussion indicate? A hyperresonant sound in percussion indicates that there is a hollow, air-containing structure under the surface. What is fremitus? Fremitus is a palpable vibration with low-frequency vocalization. So basically in this, a physician is touching the patient to feel their vibration when they make some low-frequency vocalizations, such as by saying the number 99. So you could try it on yourself by saying the word 99 while you're holding your chest, and you will feel the vibration. So that's basically what fremitus is. What is tracheal deviation? Tracheal deviation is the shifting of the trachea that occurs from unequal intrathoracic pressure within the chest cavity. What is pleural effusion? Pleural effusion is a buildup of fluid between the layers of tissue that lines the lung and chest cavity. Describe all the physical findings observed in pleural effusion. In pleural effusion, there would be decrease in breath sounds, a dull percussion, and decrease in fremitus. What is atelectasis? Atelectasis is defined as the collapse or closure of the lung, resulting in reduced or absent gas exchange. What physical findings are observed in atelectasis? Physical finding observed with atelectasis includes decrease in breath sounds, dull percussion, decrease in fremitus, as well as tracheal deviation towards the side of lesion. So basically it has everything as pleural effusion plus the tracheal deviation towards the side of lesion. What is spontaneous pneumothorax? Spontaneous pneumothorax is a collection of air or gas in the space between lungs and the chest that collapses the lung and prevents it from inflating completely. What physical findings are observed in spontaneous pneumothorax? In spontaneous pneumothorax, there is a decrease in breath sounds, there is hyperresonant percussion, decrease in fremitus, and there is tracheal deviation towards the side of lesion. What is tension pneumothorax? Tension pneumothorax is the progressive buildup of air within the pleural space. This usually happens due to lung laceration, which allows air to escape in the pleural space but not to return. So this air builds up and ends up collapsing the lung. What physical findings are observed in tension pneumothorax? In tension pneumothorax, just like spontaneous pneumothorax, you have the decrease in breath sounds, hyperresonant percussion, decrease in fremitus, but the only difference between the two is that there is tracheal deviation away from the site of lesion. What physical findings are observed in lobar pneumonia and pulmonary edema? In lobar pneumonia and pulmonary edema, you would hear crackles on inspiration. There would also be dull percussion and increase in fremitus. So remember, anytime you see an increase in fremitus, always think a consolidation process. Lung cancer. Describe the epidemiology of lung cancer. Lung cancer is the leading cause of death in both men and women. Describe how lung cancer presents. Lung cancer can present with cough, hemoptysis, bronchial obstruction, wheezing, pneumonic coin lesion on X-ray, or non-calcified nodules on CT. So basically, lung cancer can present after coughing up blood and things like that, but in a lot of cases, lung cancer is also detected accidentally on imaging. What are all the sites where lung cancer can metastasize from? Lung cancers most often come from a primary site in the breast, colon, prostate, and bladder. So remember, metastatic cancers are the most common cause of lung cancer, so cancer will originally arise in a different tissue, but will metastasize to the lung. Where do primary lung cancers metastasize to? Primary lung cancers will go to sites such as the adrenals, brain, bone, and the liver. What are all the complications that can arise due to lung cancer? Most of the complications that arise due to lung cancer arise due to the size of the cancer. So because the tumor is large, it causes compression on some certain areas and therefore leading to complications. So these complications include the superior vena cava syndrome, and in this the tumor compresses the superior vena cava and therefore the blood from the head is not able to drain into the right heart, causing the superior vena cava syndrome. Also Pancoast tumor, which is tumor at the apex of the lung, and this causes a compression of the cervical sympathetic plexus. Next complication is Horner syndrome, which is a triad of drooping of eyelids, also known as ptosis, miosis, which is constriction of the pupils, and anhidrosis, which is decreased sweating. And this all occurs in Horner syndrome, again due to the same reason, because there is the compression of the cervical sympathetic plexus. There is also endocrine complication due to the paraneoplastic syndrome that arises due to cancers. Recurrent laryngeal nerve can also get compressed due to the cancer, and this will cause hoarseness. And the last complication due to lung cancer is effusion, and it could be pleural or pericardial effusion. What is the mnemonic to help you remember all these complications that can arise due to lung cancer? The mnemonic is to remember the word SPEAR. The S stands for superior vena cava syndrome, P stands for Pancoast tumor, H stands for Horner syndrome, E stands for endocrine complication, R stands for recurrent laryngeal symptoms, and E stands for effusions. Now, last bit of information I would like to mention here is that all lung cancer types, except for the bronchiolo-alveolar and the bronchial carcinoid, are associated with smoking. What is the epidemiology of adenocarcinoma of the lung? Adenocarcinoma of the lung is the most common primary lung cancer. It occurs in 50% of all cases, and is also the most common lung cancer in lifelong non-smokers. Name the two subtypes of adenocarcinoma of the lung. The two subtypes of adenocarcinoma includes the bronchial and the bronchiolo-alveolar subtype of adenocarcinoma. What is the location where bronchial and bronchiolo-alveolar subtype of adenocarcinoma arise? Bronchial and the bronchio-alveolar subtype of adenocarcinoma arises in the peripheral parenchyma, often in sites of prior injury or scarring. This makes sense because it's affecting the bronchioles, so it makes sense that it would be in the periphery. What are some characteristic features of the bronchial subtype of adenocarcinoma? The bronchial subtype of adenocarcinoma is the most common lung cancer in non-smokers and females. This cancer can also arise when you see activating mutation of the KRAS gene, and you also see hypertrophic osteoarthropathy with this, which is the nail clubbing. What are the characteristic features of the bronchiolo-alveolar subtype of adenocarcinoma? Bronchiolo-alveolar subtype of adenocarcinoma is a cancer that grows along the alveolar wall. In this, you see alveolar wall thickening. On chest x-ray, you would also see hazy infiltrates similar to what you see in pneumonia, but in this, there is excellent prognosis. What is squamous cell carcinoma of the lung? Squamous cell carcinoma of the lung is a lung cancer that is more common in men than in women. It's a cancer that is centrally located and it presents as a hilar mass arising from the bronchus. What are some characteristic features of squamous cell carcinoma of the lung? Squamous cell carcinoma of the lung can become a large tumor which may undergo central necrosis. When it goes through central necrosis, this area of necrosis will result in cavitation, and therefore one of the features of squamous cell carcinoma is cavitation. This cancer is also associated with cigarette smoking, and there's hypercalcemia that's seen with this because this tumor will produce parathyroid hormone related peptide, and so when there is too much parathyroid hormone activity, this leads to hypercalcemia of malignancy. The reason for this is because parathyroid hormone releases the calcium from the bone, resulting in hypercalcemia. So to summarize that, remember, with squamous cell carcinoma, you see cavitation is associated with smoking, and there's hypercalcemia. What is the mnemonic to help you remember all these features of squamous cell carcinoma? The mnemonic is to remember all the C's because it's centrally located, there's cavitation, it's associated with cigarettes, and there's hypercalcemia. What histologic findings would you observe in squamous cell carcinoma? In squamous cell carcinoma, you would see keratin pearls and intercellular bridges. One additional thing to note about this cancer is that it can be resected surgically if it is detected before metastasis. What is small cell or oat cell carcinoma of the lung? Small cell or oat cell carcinoma of the lung is a cancer that arises centrally in the lung, and it's a cancer that's very aggressive and highly malignant. What are some complications that can arise due to small cell carcinoma of the lung? The complications that can arise due to small cell carcinoma of the lung includes an excess production of adrenocorticotropic hormone, which in turn leads to excess cortisol, therefore causing Cushing's type syndrome. In this, there would also be excess ADH release, which will lead to syndrome of inappropriate antidiuretic hormone, which would lead to hyponatremia and fluid retention. And lastly, small cell carcinoma of the lung can produce antibodies against the presynaptic calcium channels, which are the calcium channels at the neuromuscular junction, and this will lead to Lambert-Eaton syndrome. What type of mutation is commonly seen in small cell carcinoma of the lung? In small cell carcinoma of the lung, you commonly see amplification of the MYC oncogene. Describe the treatment option of small cell carcinoma of the lung. Small cell or oat cell carcinoma of the lung is inoperable because it generally metastasizes early in its onset, so therefore you cannot surgically resect it, but you could treat it with chemotherapy even though it has poor prognosis. Describe the histologic findings observed in small cell or oat cell carcinoma of the lung. Small cell or oat cell carcinoma of the lung is a neoplasm of the neuroendocrine Kolchitsky cells, so therefore you would see small dark blue cells under histologic examination. What is large cell carcinoma of the lung? Large cell carcinoma of the lung is a highly anaplastic, undifferentiated tumor of the lung that arises peripherally in the epithelial cells of the lung. What type of prognosis is seen with large cell carcinoma of the lung? Large cell carcinoma of the lung generally has a poor prognosis. What are some treatment options in large cell carcinoma of the lung? Large cell carcinoma of the lung is not very responsive to chemotherapy, so you could treat it surgically, but it only works in about 50% of the case to remove it surgically. Describe the histologic findings observed in large cell carcinoma of the lung. In large cell carcinoma of the lung, you see the characteristic pleomorphic giant cells, hence the name large cell carcinoma. What is bronchial carcinoid tumor? Bronchial carcinoid tumor, which is also known as typical pulmonary carcinoid tumor, is an uncommon low-grade malignant lung mass that is most often in the central airways of the lung. This is a tumor with excellent prognosis, and metastasis is very rare. What are some symptoms that can arise due to bronchial carcinoid tumor? In bronchial carcinoid syndrome, you generally have symptoms due to mass effect. Just because of the size of the tumor, it will cause compression, leading to symptoms of that. But occasionally there can also be carcinoid syndrome, in which there is an elevation of serotonin secretion, leading to flushing, diarrhea, and wheezing. Describe the histologic findings observed in bronchial carcinoid tumor. In bronchial carcinoid tumor, you would see a group of neuroendocrine cells which will form a rosettes pattern, and these neuroendocrine cells will secrete chromogranin, and therefore these cells are going to be chromogranin positive. What is mesothelioma? Mesothelioma is a rare form of cancer that develops in the mesothelium. Mesothelium is the protective lining that covers many of the internal organs of the body, and mesothelioma in the lungs will affect the pleura. So basically, mesothelioma is a malignancy of the pleura associated with asbestosis. What are some characteristic features of mesothelioma? Mesothelioma will affect the pleura, which is a membrane that surrounds the lung. Therefore, this will result in hemorrhagic pleural effusion and pleural thickening. What histologic finding is observed in mesothelioma? In mesothelioma, you would see psammoma bodies. Psammoma bodies, though, are not specific to only mesothelioma because you do see psammoma bodies in a lot of other cancer conditions. A few additional notes to remember about mesothelioma is that there is a high mortality rate with mesothelioma, and secondly, along with asbestos exposure, if you're also a smoker, the risk of getting mesothelioma is much higher. What is Pancoast tumor of the lung? Pancoast tumor of the lung is a carcinoma that occurs in the apex of the lung. It is more importantly known for its compression effects, so if it gets large enough in size at the apex of the lung, it will compress the cervical sympathetic plexus, which will lead to Horner syndrome. It can also compress the brachial plexus, which will lead to weakness in the arms and hands, and it can also compress the recurrent laryngeal nerve, which will lead to hoarseness. What is Horner syndrome? Horner syndrome is a triad of ipsilateral ptosis, which is drooping of the eyelids, meiosis, which is constriction of the pupils, and anhidrosis, which is decreased sweating. What is superior vena cava syndrome? Superior vena cava syndrome is an obstruction of the superior vena cava that impairs blood drainage from the head, neck, and the upper extremities. So basically, the superior vena cava cannot drain into the right side of the heart because there is an impairment in the blood drainage due to compression or obstruction. What are some common causes of superior vena cava syndrome? Superior vena cava syndrome commonly is caused by malignancy, which will cause the compression of the superior vena cava, or due to thrombosis from indwelling catheters. What are the signs and symptoms observed in superior vena cava syndrome? In superior vena cava syndrome, due to the impairment of blood drainage from the head, this will lead to facial plethora or facial swelling, along with headache, dizziness, increased risk of aneurysm, and rupture of cranial arteries. Also, due to impaired blood drainage from the jugular, you would see jugular venous distension. And lastly, there would also be blockade of blood from the upper extremities, therefore leading to edema. And remember, this is a medical emergency, so treatment needs to be provided right away. Pneumonia. What is lobar pneumonia? Lobar pneumonia is a type of pneumonia that affects one or more lobes of the lung. It's a condition in which there is intra-alveolar exudate that leads to consolidation, and consolidation means that there is fluid inside the lung. What are all the organisms that can lead to lobar pneumonia? Lobar pneumonia commonly occurs with strep pneumoniae, but it can also happen with Klebsiella. What is bronchopneumonia? Bronchopneumonia is a type of pneumonia in which you see acute inflammatory infiltrates from the bronchioles into the adjacent alveoli. This type of pneumonia has a patchy distribution which involves one or more lobes. What are all the organisms that can lead to bronchopneumonia? Bronchopneumonia can occur due to strep pneumoniae, Staph aureus, H. influenza, and Klebsiella. Briefly, describe the differences between lobar and bronchopneumonia. The differences between lobar and bronchopneumonia is that lobar pneumonia is caused by pneumococci or strep pneumo in 90% of the cases, and in a few cases it's caused by Klebsiella, whereas bronchopneumonia is caused by strep, staph, H. influenza, and Klebsiella. Lobar pneumonia has a sudden onset with high-grade fever, whereas bronchopneumonia is insidious with low-grade fever. Lobar pneumonia causes consolidation of the whole lung, whereas bronchopneumonia produces patchy pneumonic consolidation. I would also like to mention here that strep pneumoniae causes bronchopneumonia in IV drug users and hospitalized patients, whereas H. influenza causes bronchopneumonia in babies and young children, and Klebsiella causes bronchopneumonia in diabetics and alcoholics. A few additional pneumonias that come under bronchopneumonia category include aspiration pneumonia, which is caused by gram-positive or gram-negative anaerobes from the mouth. There's also ventilation-associated pneumonia, which happens in intubated patient, and this is caused by staph. What is interstitial or atypical pneumonia? Interstitial or atypical pneumonia is a type of pneumonia that is not caused by one of your more traditional pathogens, but is caused by viruses such as influenza, respiratory syncytial virus, adenovirus, or it can also be caused by mycoplasma, legionella, and chlamydia. Describe the characteristic of interstitial or atypical pneumonia. In interstitial or atypical pneumonia, you see a diffuse patchy inflammation which is localized to interstitial area of the alveolar wall. This distribution may involve one or more lobes, but it generally follows a more indolent course, and indolent means that it's slow to start, so that's why this pneumonia is also referred to as walking pneumonia, because it has a gradual, slow onset. Now, one additional thing I would like to mention here is that remember, chlamydia is what's responsible for causing the community-acquired pneumonia. What is lung abscess? Lung abscess is necrosis of pulmonary tissue and formation of cavities that are more than 2 centimeters in size, and they contain necrotic debris or fluid caused by microbial infections. So basically, in lung abscess, you would see localized collection of pus within the parenchyma. What are all the causes of lung abscess? Lung abscess can occur due to bronchial obstruction, which happens in cancer, and as we mentioned earlier in this chapter, that squamous cell carcinoma of the lung will lead to cavitation, so you would see lung abscess in that. Also, lung abscess can form after aspiration of oropharyngeal content because you would get some sort of infection with the oropharyngeal content, so this happens especially in patients that are predisposed to loss of consciousness, such as alcoholics and epileptics, and they would aspirate oropharyngeal content, and this will lead to infection causing lung abscess. What are some microbial organisms that will cause lung abscess? Lung abscess often occurs due to Staph aureus or anaerobes such as Bacteroides, Fusobacterium, and Peptostreptococcus. Name the drug of choice to treat lung abscess if it's caused by anaerobes. If lung abscess is caused by anaerobes, you could treat it with clindamycin. What is hypersensitivity pneumonitis? Hypersensitivity pneumonitis is inflammation of the lungs that occurs due to breathing in a foreign substance, usually a certain type of dust, fungus, or molds. This is a condition that often occurs in farmers and those people that are exposed to bird droppings because it's one of those hypersensitivity reactions that occurs due to environmental antigen. So it's a mixed type 3 and type 4 hypersensitivity reaction due to environmental antigens, and that leads to dyspnea, cough, chest tightness, and headaches. What is pleural effusion? Pleural effusion is the excess fluid that accumulates between the two pleural layers. Pleural cavity is a fluid-filled space that surrounds the lung, so when you have excess fluid in this area instead of the normal amount of fluid, this is called pleural effusion, and this excessive amount of such fluid can impair breathing by limiting the expansion of the lungs during ventilation. Briefly, describe the difference between transudate versus exudate. We talked about the difference between transudate and exudate back in the pathology chapter, so we will highlight the facts again. Transudated fluid is the fluid that has less cell content, poor protein content, and the specific gravity is under 1.012, whereas exudated fluid is high in cellular content, rich in protein content, and the specific gravity is greater than 1.020. What are some causes that would lead to transudative pleural effusion? Transudative pleural effusion occurs in congestive heart failure, nephrotic syndrome, and hepatic cirrhosis. So in all these conditions, the transudative fluid is going through tight blood vessels. Name all the causes of exudative pleural effusion. Exudative pleural effusion occurs due to malignancy, pneumonia, collagen vascular disease, and trauma. In all these conditions, there is an increase in vascular permeability. So if you remember when we talked about exudate in the pathology chapter, we mentioned that exudative fluid and cells go through loose blood vessels. So it makes sense that exudative pleural effusion will occur in states of increase in vascular permeability. One additional thing to remember about exudative pleural effusion is that this fluid must be drained because there is an increased risk of infection. What is chylothorax? Chylothorax is a type of pleural effusion in which there is lymphatic fluid, also known as chyle, accumulating in the pleural cavity. What are all the causes that can lead to chylothorax, also known as lymphatic pleural effusion? Chylothorax or lymphatic pleural effusion can occur due to thoracic duct injury, which can happen during trauma, during cardiothoracic surgery, or due to a malignancy. Describe the appearance of chylothorax. Chylothorax or lymphatic pleural effusion has a milky appearance. This is because there is an increased amount of triglycerides in the fluid. Pneumothorax. What are some physical examination findings observed with pneumothorax? In pneumothorax, you would see unilateral chest pain and dyspnea. There's also going to be unilateral chest expansion, along with decreased tactile fremitus. And as we mentioned earlier in the chapter, that fremitus is the palpable vibration with low frequency vocalization. There would also be hyperresonance on percussion, which means that there is air-filled cavity underneath the area you're percussing, as well as diminished breath sounds. What is spontaneous pneumothorax? Spontaneous pneumothorax is when there is accumulation of air in the pleural space. What demographic does spontaneous pneumothorax commonly affect? Spontaneous pneumothorax commonly occurs in tall, thin young males because of rupture in the apical blebs. Describe the tracheal deviation that you see with spontaneous pneumothorax. In spontaneous pneumothorax, you would see the trachea deviating towards the affected lung. What is tension pneumothorax? Tension pneumothorax is a condition in which there is air that enters the pleural space, but it's not able to exit. This type of pneumothorax commonly occurs in the setting of trauma or after lung infection. Describe the tracheal deviation you would see with tension pneumothorax. In tension pneumothorax, you see the trachea deviating away from the affected lung. How do you treat tension pneumothorax? If you suspect tension pneumothorax, you have to right away do a needle decompression. You don't have to wait for a chest x-ray. Anytime you suspect tension pneumothorax, you have to do a needle decompression before even confirming the diagnosis with the chest x-ray. Respiratory pharmacology. H1 blockers. What is the mechanism of action of H1 blockers? The mechanism of action of H1 blockers is to reversibly inhibit the H1 histamine receptors, and these drugs are generally used in the treatment of allergies. Name the first generation H1 blockers. The first generation H1 blockers includes diphenhydramine, dimenhydrinate, and chlorpheniramine. So these are the drug names that contain N and ene or N and ate, such as diphenhydramine and dimenhydrinate. What are the clinical uses of the first generation H1 blockers? First generation H1 blockers are used in the treatment of allergy, motion sickness, and can also be used as sleep aids. What are the side effects and toxicities seen with the first generation H1 blockers? The side effects and toxicities of the first generation H1 blockers include sedation, anti-muscarinic effects, which means it has atropine-like effects, as well as anti-alpha adrenergic side effects such as hypotension and dizziness. What is the major difference between first generation and second generation H1 blockers? The major difference between first generation and second generation H1 blockers is that second generation is far less sedating than the first generation. And the reason for this is because second generation H1 blockers have decreased entry into the CNS. Name all the second generation H1 blockers. Second generation H1 blockers includes loratadine, fexofenadine, desloratadine, and cetirizine. So these are the drugs that have names usually ending in adine. What are the clinical uses of the second generation H1 blockers? The second generation H1 blockers are generally over-the-counter medication that is used in the treatment of allergies and chronic hives. So basically, these are the drugs that you hear all the time that is used in allergies. For example, loratadine is Claritin and fexofenadine is Allegra. Asthma drugs. Describe the goal of asthma drugs. The reason asthma occurs is due to bronchoconstriction. So basically, something causes the bronchioles to constrict, and therefore air is not able to get inside the lung, and therefore leads to asthma. Now, thinking about the goal of asthma drugs, you have to remember the things that causes bronchoconstriction. So there are two different things that would mediate bronchoconstriction. One is the inflammatory process, and two is the parasympathetic tone. Now, if you remember from the pharmacology chapter, when the parasympathetic nervous system is stimulated, you get the mnemonic dumbbells, which stands for diarrhea, urination, meiosis, bradycardia, bronchoconstriction, excitation, lacrimation, and salivation. So now, as we know, bronchoconstriction is mediated by inflammatory process and the parasympathetic tone. You have to use treatments to inhibit these pathways in order for them to be effective in asthma treatment. Name all the groups of drugs that can be used in the treatment of asthma and describe why. The groups of drugs that can be used in the treatment of asthma include beta-2 agonists because these cause bronchodilation. Also, methylxanthines such as theophylline can also be used in asthma treatment because of bronchodilation effects. Also, muscarinic agonists such as ipratropium because this will lead to prevention of the parasympathetic tone, therefore also leading to bronchodilation. Corticosteroids and antileukotrienes can also be used because they prevent late response to inflammation. Name the beta-2 agonist used in the treatment of asthma. The beta-2 agonist used in the treatment of asthma includes albuterol, salmeterol, and formoterol. Describe the use of albuterol in asthma treatment. Albuterol relaxes the bronchial smooth muscles, therefore leading to bronchodilation, and that's why it could be used in the treatment of acute exacerbation of asthma. Describe the use of salmeterol and formoterol in the treatment of asthma. Salmeterol and formoterol are drugs that are used as long-term prophylaxis towards asthma. These drugs are not used alone in the treatment of asthma, but generally are combined with corticosteroids for the treatment of asthma. What are some adverse effects seen with salmeterol and formoterol? The adverse effects of salmeterol and formoterol include tremors and arrhythmias. What is the mechanism of action of the methylxanthine theophylline? Theophylline has two different mechanisms of action. It inhibits phosphodiesterase. Now, if you look at the picture on your screen, if you see that phosphodiesterase is being blocked, therefore there is a decrease in the hydrolysis of cyclic AMP. So therefore, that means there is an increase in the amount of cyclic AMP, and therefore leading to bronchodilation. The second thing theophylline does is that it inhibits adenosine. Now, if you see on the picture on your screen, adenosine stimulation will lead to bronchoconstriction. So if you're inhibiting adenosine, this will lead to bronchodilation. What are the adverse effects of theophylline use? The adverse effects of theophylline use is cardiotoxicity and neurotoxicity. Theophylline has a narrow therapeutic index, so you have to use this drug with caution. So remember, if a person also has heart problems as well as asthma, you would not want to use theophylline because of that cardiotoxicity effects of theophylline. Name the muscarinic antagonist used in the treatment of asthma. The muscarinic antagonist used in the treatment of asthma includes ipratropium and tiotropium. What is the mechanism of action of ipratropium and tiotropium? The mechanism of action of ipratropium is to competitively block the muscarinic receptors. The mechanism of action of tiotropium is primarily to block the M3 muscarinic receptors. What are the clinical uses of ipratropium and tiotropium? Ipratropium is used clinically to prevent bronchoconstriction, and it can also be used in the treatment of COPD. Tiotropium is a similar muscarinic antagonist, but it's a long-acting muscarinic antagonist used in the treatment of asthma. Name some corticosteroids used in the treatment of asthma. Corticosteroids used in the treatment of asthma includes beclomethasone and fluticasone. What is the mechanism of action of beclomethasone and fluticasone? The mechanism of action of these corticosteroids in asthma is to inhibit the synthesis of virtually all cytokines. These drugs also inhibit the nuclear factor kappa light chain enhancer of activated B cells, and this is the transcription factor that induces the production of TNF-alpha. So basically, these drugs inhibit the production of TNF-alpha as well as some other inflammatory agents. What is the clinical use of corticosteroids? Corticosteroids are used as first-line therapy for chronic asthma. Inhaled steroids are used in asthma control, whereas the oral steroids are used in the acute exacerbation of asthma. Antileukotrienes. Name the antileukotrienes used in the treatment of asthma. The antileukotrienes used in the treatment of asthma includes montelukast, zafirlukast, and xylutin. What is the mechanism of action of montelukast and zafirlukast? The mechanism of action of montelukast and zafirlukast is to block the leukotrienes from binding to their receptor. So basically, these drugs block leukotriene A4, C4, and D4 from binding to its receptor. What is the clinical use of montelukast and zafirlukast? Montelukast and zafirlukast is used in the treatment of aspirin-induced asthma. What is the mechanism of action of xylutin? The mechanism of action of xylutin is to inhibit 5-lipoxygenase pathway. So this drug basically blocks the conversion of arachidonic acid to the leukotrienes. What is omalizumab? Omalizumab is a monoclonal anti-IgE antibody. You can remember omalizumab because it has that MAB ending, which stands for monoclonal antibody. What is the mechanism of action of omalizumab? The mechanism of action of omalizumab is to bind to unbound serum IgE. When it binds to the serum IgE, it will prevent the normal action of IgE, which is to cause degranulation of mast cells. So when this is bound to the IgE, mast cell degranulation cannot happen, and therefore asthma reaction cannot happen. When is omalizumab used? Omalizumab is used to treat allergic asthma that is resistant to inhaled steroids and long-acting beta-2 agonists. Expectorants. What is guafenicin? Guafenicin is an expectorant that thins the respiratory secretion, and because of this thinning of respiratory secretion, it allows the mucus to be easily removed. One additional thing to remember about guafenicin is that it does not suppress the cough reflex. What is N-acetylcysteine? N-acetylcysteine is an inhaled mucolytic which is used in conditions such as COPD, chronic bronchitis, and cystic fibrosis, and in these conditions it loosens the mucus plug. Also, if you remember from earlier discussions, we mentioned that N-acetylcysteine is an antidote for acetaminophen overdose, and acetaminophen is Tylenol. Bosentan. What is the mechanism of action of bosentan? The mechanism of action of bosentan is to competitively antagonize or block endothelin A and endothelin B receptors. Now, when you block the endothelin A and endothelin B receptors, endothelin 1 can no longer bind to these receptors. The normal function of endothelin 1 is to cause arterial vasoconstriction, so if you're blocking this action of endothelin 1, this means that there is going to be vasodilation, and this leads to a decrease in pulmonary vascular resistance. So, if bosentan's mechanism of action is to decrease pulmonary vascular resistance, what do you think its clinical use would be? The clinical use of bosentan is to treat pulmonary arterial hypertension. What is dextromethorphan? Dextromethorphan is a synthetic codeine analog that is used as an antitussive to suppress cough. What is the mechanism of action of dextromethorphan? The mechanism of action of dextromethorphan is to antagonize or block the NMDA glutamate receptors. What are some adverse effects of dextromethorphan? We mentioned that dextromethorphan is a synthetic codeine analog, so it does have mild opioid effects when used in high doses, so there is some degree of abuse potential with this drug. How can dextromethorphan overdose be treated? Dextromethorphan overdose can be treated with naloxone, which is an opioid antagonist. What is the mechanism of action of pseudoephedrine and phenylephrine? Pseudoephedrine and phenylephrine are sympathomimetic alpha agonists over-the-counter nasal decongestion. These drugs' main function is to cause vasoconstriction, and this leads to less nasal tissue swelling and congestion. What are all the clinical uses of pseudoephedrine and phenylephrine? Pseudoephedrine and phenylephrine can be used to reduce hyperemia, edema, and for nasal decongestion. These over-the-counter drugs can also be used to open obstructed eustachian tubes, and pseudoephedrine may also be used as a stimulant. What are some adverse effects of pseudoephedrine and phenylephrine use? The adverse effects of these include hypertension. Pseudoephedrine also has some abuse potential because it can easily be reduced to methamphetamine, which is done often in meth labs, so there is definitely an abuse potential with pseudoephedrine. What is methacholine? Methacholine is a short-acting muscarinic receptor agonist. Because it activates the muscarinic receptors, this would cause bronchoconstriction. So because it causes bronchoconstriction, you would not want to use this in the treatment of asthma, but it's used in the asthma challenge test to diagnose asthma. This marks the end of the respiratory chapter.